Medicine General Ahmad Yani University, Dr. Absep Kurniawan, SE, MT, ASCA, CHRA, MIP. The Honorable Vice Chancellor of the Faculty of Medicine, General Ahmad Yani University, Dr. Dewi Rati Handayani, Magister Kesehatan. Also, the Honorable Dr. Odi Faruzi, Specialist Anesthesi, and our Dean of FK Unjani, Dr. Wendra, Dr. Magister Kesehatan, and then Dr. Raditya Jati, SSI, MSI, and the last is Dr. Bagus Tahsono, MPH. And before that is the last of it is Dr. Glenn Gladi Prakasa. Well, before we get to the main event, there will be singing the Indonesia Raya song first, followed by welcome speech from the Chief Executive, the International Jamboree and Scientific Meeting, and then Faculty of Medicine General Ahmad Yani University, and also the Dean of FK Unjani. Well, maybe let's go straight to the next event, which is singing the Indonesia Raya song.
Well, after this, there will be welcome speech from the International Jamboree and Scientific Meeting, Faculty of Medicine, General Ahmad Yani University. For Dr. Odi is welcome.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Greetings and warm welcome to our expert team, our Dean, Dr. Wendra, health professional and student, participant and enthusiasts. It's time to kick off an exhilarating celebration of friendship, culture, and adventure. It's an archipelago located at the confluence of four tectonic plates. Indonesia has various potential. The large number of river and active volcanoes in residential area potentially cause Indonesia to experience earthquake, landslide, floods, tsunami, and volcanic eruption. Extreme weather and earthquakes that have recently happened in almost all regions of Indonesia are the source of evidence. In additional natural disaster, Indonesia can experience man-made disasters such as air population, fire, traffic accidents, and exposure to hazardous chemicals. The highest number of potential disaster in Indonesia makes awareness of disaster necessary for everyone. Following the vision and mission of Faculty of Medicine, University Jenderal Ahmad Yani in Medical Emergency and Disaster Management. The International Jamboree 2024 will carry the dome together, aligning medical capability and building resiliency of medical teams in disaster preparedness. This event aims to increase awareness and preparedness for disasters so that disaster loss and victim can effectively be minimized. This jamboree is greeting like no other, bring together individuals from diverse background and experience, united by shared passion for exploration and discovery. This is a unique opportunity for us to share knowledge, exchange experience, and inspire one another to reach new heights in our noble professionals. As we embark on this journey together, let us celebrate the spirit of friendship, respect, and collaboration. Let's embrace the difference that make us unique and the similarities that blind us as one global family. Throughout this event, let's seize every population to learn, grow, and create lasting memories from thrilling activity to engaging workshop. There's something for everyone to enjoy the cherish. Throughout this event, let's explore innovative advances in healthcare, discuss best practice, and force collaboration that will shape the future of health professional roles in disaster management. So, whether you are seasoned adventurer or a curious newcomers, let's dive into these jamborees with open heart and open mind. Together, we will make this event an unforgettable experience for all. Welcome, one and all, to the second Jamboree, to the second International Jamboree Faculty of Medicine, University Jenderal Ahmad Yani. We are looking forward to see our here in Bandung on July 2024. Thank you.
Thank you very much for Dr. Odi for his remarks. Next, there will be a welcome speech from the DN of Faculty of Medicine, General Ahmad Yani University. For Dr. Wendra, welcome.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Yang saya hormati para pejabat struktural di lingkungan FK Unjani, yang saya hormati Dr. Raditya Jati, SSI MSI, selaku Deputi Bidang Sistem dan Strategi BNPB, yang saya hormati Profesor Dato Sri Abu Hasan Asari, yang saya hormati Dr. Bagus Cahyun MPH, yang saya hormati Dr. Glenn Gladi Prakasa selaku narasumber, dan tentunya yang saya hormati Dr. Odi Farozi, spesialis anestesi selaku Ketua Pelaksana Jamboree, yang tentunya seluruh peserta webinar serta panitia penyelenggara yang saya banggakan. Hadirin yang saya hormati, pertama-tama marilah kita panjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala, Tuhan Yang Maha Esa, karena berkat rahmat dan hidayahnya kita bisa berkumpul pada pagi ini dalam keadaan sehat walafiat. Sebagaimana kita ketahui bahwa Indonesia seringkali dilanda bencana karena dikarenakan letak geografis Indonesia yang terletak di pertemuan tiga buah lempeng tektonik, di lempeng Eurasia, lempeng Indo-Australia, dan lempeng Pasifik. Tentunya kondisi ini menimbulkan potensi bencana alam seperti gunung berapi, tsunami, banjir, tanah longsor. Beberapa bencana alam yang pernah terjadi di Indonesia merupakan bencana alam yang besar dengan korban jiwa dan kerugian material yang cukup besar. Oleh karena itu, berupaya untuk pencegahan dampak bencana alam tersebut. Sebagai institusi pendidikan, Fakultas Kedokteran Unjani bersama dengan BNPB selalu berusaha untuk berperan aktif mensosialisasikan pemahaman tentang bencana dan peran bidang kesehatan dalam suatu manajemen bencana dengan harapan insan kesehatan dapat ikut berperan dalam penanganan bencana tersebut. Berdasarkan alasan tersebut, FK Unjani pada kesempatan hari ini menyelenggarakan kegiatan webinar dengan tema Health Aspect in Disaster Management. Selain itu, kegiatan ini kami gunakan juga sebagai acara untuk mempromosikan kegiatan tahunan FK Unjani, yaitu International Jamboree yang akan dilaksanakan pada bulan Juli tahun 2024 ini. Kami berharap setelah mengikuti kegiatan ini, para peserta memiliki pemahaman yang sama tentang apa yang akan kita lakukan selaku insan kesehatan jika terjadi suatu bencana. Akhirnya, saya ucapkan selamat melaksanakan webinar. Semoga dapat bermanfaat untuk semua. Mohon maaf apabila dalam penyampaian sambutan ini terdapat hal yang kurang berkenan. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Wendra, for the speech. Well, after the welcoming words, there will be some material that will be guided by the moderator. And for the honorable moderator, Dr. Aya Vedanugraha, Dr. Magister Kesehatan. Before that, allow me to read CV of our moderator. Alright, education background, Universitas Pajajaran 2021 sampai 2023. Kemudian Universitas Islam Indonesia 2011 sampai 2017, Universitas Pajajaran 2019 sampai 2021, Senior High School 1 Kebumen 2008 sampai 2011, Secondary High School 1 Kebumen 2005 sampai 2008, Elementary School 1 Kebumen 1999 sampai 2005. Mungkin bisa di next. Untuk achievement, cum laude predicate of doctoral degree 2023, cum laude predicate of master degree 2021, awardee of PMDSU scholarship batch 5 for master and doctoral degree 2019, cum laude predicate of proficient degree 2017 and the other. For the experience, staff of Department Pharmacology at Faculty of Medicine, Universitas Jenderal Ahmad Yani, international collaboration research and publication with University Nijmegen, supervised by Prof. Rob Amutse 2019-2023, employee at Sambada Clinic Februari 2019, August 2019, employee at Depok Clinic Februari 2019, August 2019. For the conference or seminars, oral presenter Indonesia Tuberculosis International Meeting, Universitas Pajajaran Indonesia, August 2021, poster presentation 10 International Medical Education Conference, International Medical University Malaysia, April 2015. For the research experience, development and validation of volumetric absorptive microsampling method for chlorpromazine analysis in multi-drug resistant tuberculosis and the other. For the publication, first, analytical and clinical validation of ZEISS for volumetric absorptive microsampling. Second, chlorpromazine as a treatment for multi-drug resistant tuberculosis and traditional herbal medicine candidates as complementary treatment for COVID-19. Maybe that's all for the CV. For Dr. Rea is welcome.
Okay, thank you for the master of the ceremony of this event. First of all, Assalamualaikum warahmatullahi wabarakatuh. Good morning and welcome to today's webinar about health aspect in disaster management, brought to International Jamboree Faculty of Medicine, Universitas Jenderal Ahmad Yani 2024. My name is Rea Vedanugraha and I'll be your moderator for today's webinar. To give you an overview of what we'll be discussing, we'll be covering the overview of health aspect in disaster management, health emergencies in natural disasters, crash syndrome, and last but not least, Jamboree presentation. We'll have some time for question and comments at the end of our speaker presentation. As participant, you are encouraged to ask questions, share your thoughts, and present any relevant examples. This is meant to be an interactive discussion, so don't hesitate to contribute with your insight. We have an excellent agenda for you today, where we'll cover for the following main points. 1, the overview of the health aspect in disaster management or keynote speaker. 2, health emergencies in natural disaster. 3, crash syndrome for Jamboree presentation. Throughout the webinar, we encourage you to take notes and hold on to the questions you might have until the end. We'll aim to answer as many questions as possible during the allocated Q&A time. Without further ado, let's dive into today's discussion. Now it's time to hear from our first speaker. Here's the CV of our speaker. Yeah. He's a distinguished disaster management and resilient expert, currently serving as Deputy Minister of System and Strategy at the Indonesian National Disaster Management Authority, or BNPB. He also has played a pivotal role in shaping disaster management policies in Indonesia and beyond. Dr. Aditya Jati has published numerous articles on this subject, including the annually released Disaster Risk Index of Indonesia, has been involved in so many international activities and scientific projects since 1999 and has received many international awards since 1999 for his work, including the German Academic Exchange Service, the AAD, and Ritsumeikan University, Japan, and also attended professional training in national and international level. He acquired his doctoral degree in environmental science from the Sandwich Program of Universitas Gadjah Mada and the University of Utrecht in the Netherlands. Please join me in welcoming Dr. Aditya Jati, SSE, MSE, as our keynote speaker. Hello, Dr. Aditya Jati. The room and place are yours for 10 minutes.
Thank you, Dr. Ria, and also Mr. Dean of Faculty of Medicine, Dr. Wendra, and also Dr. Odi as a chairman, also friends, colleagues. Please allow me to say thank you very much for inviting us, and also it's a good pleasure for us to be here. May I share some slide? I know there's many slides here, but I will try to be precise on the time. Please remind me, Dr. Ria. So I would like to introduce what is actually the disaster management actually is and what is related to the medicine issues that we are talking today. So if I may, this is the background, the condition of Indonesia. You have seen that also Dr. Wendra mentioning about the potential risk of Indonesia. The Pacific Ring of Fire, we are also in an archipelagic state. This is also mentioned in the Sendai Framework for Disaster Risk Reduction document in the UN document, and also the large number of population. It means that we are in a high risk. This is why we are very sure that disaster management is very important for us in the country. Last year, we have also more than 3,000 frequency disasters that happened in the country. And this year, until this May, we have 700 frequency of disaster. And mostly it's a 98% of hydrometeorological. It means that it will impacted to flood, landslide. But the victim can be more than a geological impact, including earthquake and tsunami. The history of BNPB actually was mandated by the law number 24, 2007. That is when BNPB established by the law in 2008, and 2007 was the law. And until now, BNPB have the function of coordinator, commander, and implementator. It means that we have not only the function of coordinating, but also implementation during the disaster, when the disaster happened, before the disaster happened, during the disaster happened, and also after the disaster happened. This is when emergency response and recovery is also important for us. And this is the organization structure. We have 5 deputy and 2 structural high level. And in the beginning of the analysis, it is very important that we have to have a risk analysis when probability and also the hazard come from. According to the United Nations for Disaster Risk Reduction, there's no such thing as a natural disaster. There's only natural hazard because it was involved already with the spatial planning, induced people, impacted people, and also infrastructure, also climate change, and also impacted by environment degradation. That's why it's important to see that what is actually at our risk. This is, you can download it now. It's an INARIS. This is a web page and also a personal personal in our risk. You can see where am I, or it's my risk, how can I really deal with the risk, and how I can really deal with that. So you can also overlay with other issues, including 13 hazard that we have of this banjir bandang, and also liquefaction. That's why it's very important that we have to know where we are, what kind of risk we are facing, and how we can really deal with it. So this Inaris personnel, actually, you can see how many schools are there, how many hospitals are there, how many puskesmas are there. So you can really know how many possible risks that can happen in every hospital that we have in the country. So our target is to make ourselves a resilient country. It means Indonesia resilience beginning from the family, community, village, and also the regency and also province. That's why the National Disaster Management Authority have the responsibility to coordinate and so to implement all the issues on disaster management, including preparedness, mitigation, response, and recovery. This is the whole cycle of disaster. And this should be done professionally and also coordinating with other line ministry, including media, academician. This is where Unjani is coming, and also the private sector, and also community. The component of disaster preparedness really needs the knowledge and risk and skill on how we can really build our self-resilience, including public education, early warning system, life safety, response mechanism and strategies. Community-based is also important for us, and also provision of supportive resources, management and coordination preparedness plan. That's why hazard, vulnerability, and capacity is very important. This is where how we can really reduce the risk itself. With raising the capacity, the ability of the people of the organization to know the skill and knowledge and resource to manage the disaster. So the academician plays a very important role how we can really understand the risk and to reduce the risk itself by raising the capacity of the people. Now we have known that risk is very systemic. There's a cascading and collateral impact on every risk. So when the disaster came, and it can also impact it to health, it can impact it to other cluster, including also when we have people, displaced people now, and how we can relocate, and how many people are living in the tent for during the emergency response. It is very important that the cluster of health is very important to manage the disaster during the emergency response. And you will hear about that with Dr. Douglas, is our expert on that. The Secretary General of United Nations also mentioning that there's nothing undermines sustainable development like disaster. It means it's related on climate change, environment degradation, disaster risk reduction, and also development goals. That's why in 2015 until 2030, we have to really understand the risk. We have to strengthen ourselves, the governance, to invest the DRR itself. And when disaster happen, we have to build ourselves, rebuild, and how to build back better. The three main agenda in 2015 is very important. During the Paris Agreement was also established and mandated at that time, and also disaster risk reduction during the Sendai framework and Sendai, and also SDGs. This all three big agenda is already also involved into the local, and the national and local framework, including now SDGs. We have SDGs village or SDGs desa. That's why it's very important, including in health sector, where it's very important to maintain the resiliency, health resiliency. All this is also mandated under the Presidential Decree number 87/2020, where the master plan, this is the first time that we have the 100 years independence of Indonesia Emas, that this master plan was established in 2020 for until 2045. This is the first time that we have the long-term master plan that will be embedded into the National Disaster Management Plan every 5 years. Then it will be also as a minimum service standard accordingly with health sector that also have the minimum standards. In 2022, we have the opportunity to host the United Nations countries in Bali at that time, during the Global Platform for Disaster Risk Reduction. This is the first time that Indonesia, or in Asia, as a hosting country with 185 countries there. And our president have mentioned about the 4 concepts of sustainable resilience to the global community. including number 4, where the Paris Agreement, Sendai Framework, and also SDGs into one to put it into national and local level. This is how we can really put all together, and it's already agreeable on also in the ASEAN Leader Declaration 2023, where all the head of state agree upon that promoting sustainable resilience is enabling framework for us. So what does it really mean, sustainable resilience? Is strengthen the climate and disaster resilience for sustainable development. And the people center is very important on how to really put the governance, investment, and infrastructure in science technology. For our activities also including in helping other aid to other disaster that happen in other countries. This is also where team of the medicine also going to Turkey also to rescue for earthquake during that time, also cyclone, and also in Syria earthquake. So the responsibility of Indonesian also help the other country as a soft diplomacy to increase cooperation and also solidarity with other country and humanitarian assistance. Also, we have a capacity building that include also a health sector, how to face disaster during disaster happen. Simulation is very important. Education drill is very important, including safe school program. So I will be grateful if Unjani have a program for schools where students can go to schools and tell the students on how safe school programs should be done. Including, we also very grateful if some of the academician and also students, including health sector, involved during the emergency response and recovery. I think this is one of the good collaboration among us, among government, private sector, community academician, and also media. So one of the issues that are now in the past 2 years, I think we all faced the COVID-19, where BNPB has also been as the task force mandated by the president, because it was mentioned that COVID-19 is a national disaster. That's why the head of BNPB is responsible on one command on that, where national level until district and village level is very important on how we really can coordinate on how we can protect the people, and not only on testing, tracing, and treatment, but also on prevention, on using masks, and also treatment, and also support and counseling. So it's very important for the leveling of the coordination of us. In health sector is very important on precondition and how we can really put the monitoring evaluation as one of the things that we have to put as a public policy or to increase the health resilience of the country. As you might know, BNPB is also coordinating with the Minister of Health on how we can really put this village district level in Indonesia, including with the Minister of Home Affairs, how we can really put the zonation of the people using the mask on how really they are considered that the health is a very important issues for us, and to be there to be together against the COVID-19 at that time. That's why we need a strategy, structure, and system and scale to speed up target that Indonesia should be resilient in that time, including from the central government, regional government, community, and household. That's why our target is individual and collective discipline on effectiveness of the behavioral change, where domestic production on how we can really implement the health resiliency for the COVID-19 at that time. So now we have to be aware that disaster is something that is a very high uncertainty and very complexity. That's why the challenge is how the commitment of the local leader, including the government, including all the leader, even in the local leader, community leader, is very important that they understand what the risk and the challenges. And you might have seen that risk now is a very complex and unpredictable, and that's why we have to build bridges among us, including us from the government to the academician, that we're now in this very important event, road to Jamboree, important to align the initiative to break silo. And I think this is my keynote speech to bring the spirit on how we can really put disaster management into health sector. I hope that we can continue the good collaboration among BNPB. So Unjani, thank you very much for the time, and I'm giving back the time to the moderator. Thank you very much.
Thank you, Dr. Aditya Jati, about your presentation. I'm sure our audience has learned a lot from you today about Indonesia has many ways of natural disaster, how to know about natural disaster in our area, especially using the INARIX application, and etc. Okay, before we move on to the Q&A session, we move to our second speaker first. We will have the discussion session at the end of all the speakers' presentation. Here's the CV of our second speaker. Our second speaker is also an expert in disaster management and resilience and works at the Indonesian National Disaster Management Authority, or BNPB. He has published several articles, has been involved in international activities and courses, and has received many international awards for his work, including from the MPRI, Bosnia-Herzegovina, and Eastern Slovenia for the UN Peacekeeping Medals. Also attended various professional training in national and international levels. He acquired his master's degrees in public health from the University of South Carolina in the USA. Please join me in welcoming Dr. Bagus Cahyono, MPH, who will be presenting the topic of health emergencies in natural disaster.
Ya,
Hello, Dr. Bagus.
ya saya izin share ya.
Siap.
Saya
Mangga,
coba.
Dok. The room and place are yours for 30 minutes, Dok.
Ya, saya coba share ya. Kelihatan anunya?
Terlihat, Dok?
Bisa terlihat anunya?
Terlihat.
Udah bisa.
Sudah, Dok.
Oke. Oke, good morning.
Mungkin di full screen dulu, Prof. Dr. Bagus izin.
Yeah, thank you. Good morning, all. I want to talk briefly about health emergency and response mechanism, especially in Indonesia. Yeah. The agenda today, first is disaster emergency command system. Second, health crisis approach. 3, initial emergency response, health cluster, and then emergency medical team, and preparedness message. Yeah, I will deliver this very briefly following the time. Okay, as mentioned by previous speaker, Dr. Radit, disaster in Indonesia is increasing time by time, caused primarily by hydrometeorologic disaster. It means weather and climate-related disaster, and then caused by geological disaster. And this is very important natural disaster because geological disaster like earthquake contribute to the destructive infrastructure and also claim more life compared to hydrometeorological disaster. Yeah. And very important to note, be mentioned here, is that every natural disaster will be followed by a health emergency, ranging from mild to severe. So every natural disaster will be followed by a health crisis. This is 6 health problem that can cause emergency during a natural disaster. First is injuries or trauma. This is very pretty obvious because injuries are the first impact that must be addressed, especially during earthquake. Yeah, also need to set up temporary triage, and then earthquake tends to result in highest number of injuries compared to other events such as tsunamis, flood, storm, and wildfires. The second is, sorry, chronic disease emergencies. This is especially those living with diabetes, kidney disease, lung disease, or other condition requiring constant care will often be the first to suffer if healthcare services are interrupted. And then hygienic impact and the spread of disease. This is very important, especially we have a massive internally displaced person or refugee. So this is a health problem is very, very important. Because natural disaster destroy infrastructure, water pipe, gas line, and then contaminated water. The lack of a functioning sewer system also can result in the spread of disease. Yeah? And then also sustained power outages can cause food shortages, lost medicine, and inability to run healthcare facilities safely. The fourth is food shortages. This is very obvious also. One short-term consequences of the natural disaster is the issue of food shortages. Interrupted supply logistics in the area, damage to the farm and factories could also spark longer-lasting food shortages. This can lead to an increase of food prices and putting a financial burden to the population. The fourth is what we call it silent trauma, mental health problem. The trauma of experiencing a natural disaster can cause widespread mental health problem. Immediate mental impact includes shock and grief. But as victims suffer the loss of home, business, and loved one, they can often face longer-term problems such as post-traumatic stress disorder or PTSD, depression, and anxiety. Lastly, the damage to the healthcare infrastructure. Physical damage to the hospital and other healthcare facility can lead to a public health crisis for some citizens. In the time also medicine are lost, equipment is damaged or destroyed, and hospital facilities are unable to treat patients adequately. In the case, many people might also flee the area following a disaster, leaving healthcare facilities short of staff, nursing, doctors, etc. So how we handle the crisis? So we have a health crisis approach in Indonesia. We can see the combination of natural hazard, non-natural hazard, social hazard create disaster can have a negative health impact. And then negative health impact can become a lack of health capacity. So require quick response with special procedures outside of the daily routine. Many activities that we have to handle in this crisis situation: life-saving, limb-saving, the continuity of the essential healthcare. Yeah? And that in this crisis, there is a health crisis or medical crisis and public health crisis. So health crisis need emergency response, and then public health response, so we can have a robust disaster management response. As mentioned before by a previous speaker, in health crisis cycle, we have, we call it pre-disaster, during disaster, and post-disaster. In terms of health, we have a pre-health crisis, and then move to the health crisis emergency response, and then we have post-health crisis. So in the states of pre-health crisis, we have health crisis risk reduction. And then we have a rapid health assessment, and then we come to the health recovery for rehabilitation and reconstruction. This is all the cycle of health crisis management. This is the general formula that Dr. Radit mentioned briefly. I just try to mention briefly. This is about what we need to focus on this formula, that we have to reduce the risk by manage the hazard, and then we have to reduce the vulnerability, and then improve the capacity. Yeah, like health crisis mapping, policy, command and coordination system, early warning system, human logistic, health logistic, and community empowerment. This is the German formula for responding, facing for the potential risk. So now we come to the disaster emergency management command system. We call it in Indonesia Sistem Komando Penanganan Darurat Bencana. This is very, very important disaster response system in Indonesia. We adopted from ICS, from the US, from the Incident Command System, and then we hybrid with a cluster system from the United Nations. First of all, we have to understand what is disaster emergency. Disaster emergency is a situation that threatens and disrupts the lives and livelihood of a group of people or community that requires immediate and adequate response. Immediate and adequate response measures. BNPB had regulation number 3, 2016. And then for disaster response, we have to apply the disaster emergency response management is a series of activities carried out immediately at the time of disaster to deal with the adverse impact caused, which include rescue, evacuation activities, property, fulfillment of basic needs, protection, management of refugee or displaced person, rescue, restoration of the infrastructure. This Constitution number 24, 2007. And this is very important. This is based on the study done frequency in the United Nations, coming with the statement that the most deadly killer in any humanitarian emergency is not dehydration, is not virus or measles, is not malnutrition or the weather. It is bad management who contribute to the worsening crisis situation. It means we have to conduct or have a good management in order we can handle respond or emergency situation in a good manner. That's why it is important we have the implementation of disaster emergency management command system. So everything under the command can work closely and orderly. Yeah. So disaster management command system is an integrated system by utilizing all resources in effective and efficient manners. Efficient way in managing and the impact of disaster emergency in one structural organization. So this is the flow when we have to respond during disaster. So when disaster occur, so the head of the regency, the head of the local government, either region, mayor, or governor, they will use a rapid assessment. They send the rapid assessment team to the disaster area. They gather all the important information and then put the information during a meeting with the local leaders in the table, and then the local health government, the local government will determine whether his or her area become emergency situation. And then the local leader will establish state of emergency, and then the command system activated, and then the emergency response implementation begin. That is very important. And all the activities, all the response during disaster will be under the umbrella and the supervision of the command post. Okay, this is the structure. we can see here the command post, and then under the command post, under the commander, there are many operation division that supervise a specific head cluster, including head cluster activated become health emergency operating center or HEOC, and then under the HEOC there are many, one or two or more emergency medical team coordination center, EMTCC. We can discuss later. And then after that, after we have establish a command post and all the staff under the organization, so we start the initial emergency response as soon as possible. So what we be doing during initial emergency response, there are 6 activities. First is search and rescue, and then emergency response, victim evacuation, trauma injuries, and then basic needs fulfillment, protection for vulnerable groups, and then immediate recovery, vital function, infrastructure, and facilities. Okay, first search and rescue done by our brother from our colleague from Indonesia Search and Rescue body agency. So they conduct victim search and rescue, emergency medical response, victim evacuation, and priority to seriously injured victim and vulnerable group. So the medical team will respond to help the victim or casualty after the search and rescue colleagues extract and stabilize the victim or the patient, and then the medical team can perform medical emergency activities. And then must be remembered during search and rescue, we have to remember 3S, safety for us as a helper, and then style, it means we doing medical activities professionally and competently, and then we do that with smile, caring, so we not hurt the community. Second is the most important thing after that is how we provide wash, water, sanitation and hygiene, food, clothing, etc. This is very important, will become the second disaster if water, sanitation, hygiene, and food is not provided properly, because contaminated water and food can cause cholera, maybe can kill thousands of victims. Okay, and then is we have to do for the protection of vulnerable group. This is about rescue evacuation, psychosocial, provide guarantee for protection from violence, discrimination, and then supervision of perpetrators, and then special places for breastfeeding, children playground, etc., and then assistance to elderly and brother sister with disabilities. Yeah? And then we have to clean up the infrastructure facilities, clean up for debris or garbage, hazardous materials, emergency repair of public infrastructure, road, bridges, airport, etc., and then emergency repair for supporting utilities. And then one activities that very important during response for disaster in terms of medical and health wise is health cluster collaboration approach. Because disaster is everybody business. We have to collaborate to have a successful maximum health response during disaster. So health cluster actually coming from United Nations, especially when there is a disaster, natural, non-natural, or man-made disaster that cause thousands displaced person in one area. So we have to handle in terms of specific area of responsibility. Yeah, there is a 10 under the United Nations. In Indonesia, we have 8 under BNPB regulation. First, a health cluster, search and rescue cluster, logistic cluster, evacuation and shelter cluster, education cluster, infrastructure cluster, economic cluster, and early recovery. Focus on health cluster. So we have a health cluster system for health crisis management. And then we can see this is a health cluster. We have health services, disease control, environmental health, provision of reproductive health, mental health treatment, management of death of victim, and then nutritional health service, health information, and medical supplies. And what we'll talk later is about health cluster for health services. So this is the briefly how the health services subcluster apply during response mechanism. So there is a displaced person. So we put there in the temporary evacuation post, and then we take care of the refugee or IDP if needed. And then for refugee or IDP person with trauma or injury, we do extraction, and then we do triage and resuscitation, and then we have ambulance, and we do the patient to the hospital care for emergency treatment and preventive treatment. So, and then this is the health cluster response highlights. So during disaster, there is a danger area. We do the rescue, and then we have a relief, make sure that the health program work with the minimum requirement. And this year we do a public health response team, and then we take care of the temporary displaced person in the shelter, and then move to the permanent shelter, and we do recovery, restore the program to its beginning in accordance with regional and national health development planning. This is the highlight for health cluster response. And then now we come to the topic here that we will apply during our Jamboree on July. It means how the emergency medical team work. Okay, the term emergency medical team or EMT.
Dr. Bagus, excuse me. 5
5
minutes left, Doc.
minutes, okay?
Yeah. Okay.
This is a group of health professionals providing direct clinical care. So there is a registration and credential for the EMTs.
Yeah.
Registration is the minimum capacity standard guideline. And then the credential is competency standard, train team and system. And then we have a health cluster under the engineering command system. We have here health service subcluster, EMTCC and EMT, what I mentioned before. And then this is what the health emergency operating center flow. Yeah, we do rapid health assessment, and then we determine health situation or not, and then we activate the health cluster, and then we operationalize the health emergency operating center. And then this is very important, already mentioned by Pak Radik. Preparedness is the backbone for better and faster response. Again, preparedness is the backbone of better and faster response. Good preparation will improve a faster and better emergency response. So there are 9 activities for preparedness. The 3 contingency plan, education and training, and exercise is very important to minimize the uncertainty during disaster response. So education, simulation, contingency plan is very important. And then if important for us as the health actors must be trained regularly, because training must precede disaster. Every person or group respond to a crisis is highly dependent on previous training. Yeah, it's very important to have a better preparedness. Okay, this is the last slide for me. In disaster management, we always living between two disasters. Yeah. So we have to increase preparedness. We have to have a training simulation. So we have to be prepared for responding for the next disaster. Last slide. Thank you very much. And recognize the threat, prepare the strategy, reduce the risk, and ready to fight. Back to the moderator. Thank you.
Thank you, Dr. Bagus, for your insightful presentation. I'm sure our audience has learned a lot from you today about the disaster emergency command system, health crisis approach, initial emergency response, health cluster, emergency medical team, and preparedness message. Before we move on to the Q&A session, we move to our third speaker. Here's the CV of our third speaker. Prof. Dato Sri Dr. Abu Hasan Asari Abdullah, SSAP, DIMP, QSD, AMN, MBBS, VRCS, VAMM, and VAMS. Our third speaker is an international speaker for today's webinar, a visiting professor and international senate for the Faculty of Medicine, Universitas Jenderal Ahmad Yani, and of course for other universities. He's also a visiting consultant for some hospitals, including in Jakarta, and an advisor and consultant for the Ministry of Health Indonesia. He's a former president of the Asian Society of Emergency Medicine. He is now a board member of the College of Emergency Physician Malaysia and a member of the Building Task Force in Medical Academics Building Malaysia. Please join me in welcoming Prof. Dato Sri Dr. Abu Hasan Asari Abdullah. Hello, Prof. Abu.
Hi, thank you very much. Bismillahirrahmanirrahim.
What?
Assalamualaikum and salam jatra, and very, very good morning. I'd like to thank everyone. Firstly, of course, thank you very much to the committee members who invited me to speak. And I'd like to say thank you also to Dr. Wendra, and of course, Dr. Odi, Dr. Glenn, and all the other speakers that have spoken before me, Dr. Bagus and Dr. Raditya. Firstly, I'd like to say that I'm very happy that we have started this program in order for us to prepare for the Jamboree in the month of July. And I actually have decided to present a paper that relate to a clinical syndrome, which actually in a way is a preparation for the Jamboree, but more towards the concept of clinical syndrome, or the understanding of the possible impact of the disaster. And I just want to confirm that, can you see my slide? Is my slide
Yes, Prof.
Yeah? Can you see the slide?
Yeah, you can see the slide.
Right, this is actually a lecture series on clinical syndrome in the mass casualty incidences and disaster. Now, I pick up this topic, the crush syndrome, and the management critical pathway. Now, in one of the preparation for the Jamboree, we have to know exactly the various clinical syndrome that will happen during mass casualty incidents and disaster. Now, I think the approach that we have heard from the previous two speakers is very important for the administrative preparation, for the response system, and also on the commitment of the government on providing the various aspects to make sure that the disaster management or the major incident management is effective. As you probably have heard, that without proper preparation, we will not be able to handle the disaster well, and fail to prepare, and you are prepared to fail, they were saying. Now, as far as I'm concerned, I'm now going to bring the audience and those of you who are here listening to this presentation to another dimension. This dimension is about the impact and the outcome of the disaster, in which when we prepare to respond, we must know exactly what kind of clinical syndrome that we are dealing with. Now, let me just put a few definitions, and also kindly stop me if I'm beyond time because my presentation can be very long. But anyway, I'm trying to make it concise and precise. Now, first and foremost, we must understand some definition and terminology. And also, we must understand the anatomy of the disaster, what we call the biomechanism of the disaster, and the physiology of the disaster, the clinical manifestation. And I'm going to focus a little on the crush syndrome, the pathophysiology and the metabolic response, and some of the processes, which I may not go into specific, but just to show some of the process and procedure for managing the crush syndrome. Now, as you all probably know, the clinical syndrome in major incident is important because different disaster will provide different clinical syndrome. Now, we all probably already know, we heard just now that the definition of disaster, and usually it refers to a natural calamities that relate to flood, earthquakes, and volcano. And you have seen just now the slide on the seismic belt and on the ring of fire that where Indonesia, the Philippines, and Japan are all located. And we in Malaysia is very lucky that we are surrounded by the ring of fire, but Alhamdulillah, we have not got our own natural disaster, but we are actually quite unfortunate too that we have created our own disaster, what we term as mass casualty incident or man-made or human-related calamities. Now, as I was saying, the anatomy of the calamities refer to biomechanism of the incident, earthquake, crush, fire, burn, flood, near drowning, sharp object, bleeding and hemorrhage. And this is a kind of understanding that we must have. And of course, the physiology of disaster refers to the pathophysiology, the metabolic response to the incident. Now, this must be understood by the responder for us to bring adequate equipment, adequate medication for the purpose of intervention. Like we said, that if we go to war without weapon or without bullet, then we may not be able to win the war. Precisely when we go to an incident site, we must bring the appropriate equipment and appropriate medicine to intervene. Now, clinical syndrome, the critical success factor in the intervention is really to understand the relationship between the anatomy, the physiology, and the clinical manifestation of the calamity and disaster. In the preparation of disaster response, the responders must equip themselves with the appropriate equipment, medication for the intervention. Now, this must be supported by the knowledge about the clinical syndrome of the calamities. Now, the clinical skill on site intervention must also be supported by accurate knowledge of the clinical syndrome and the manifestation of the survivors of the calamities. Now, for definitive care of the intervention at either the field or the primary responding hospital at the rumah sakit, the appropriate information on the quantity and the clinical syndrome of the survivors of the calamities must be understood. As you probably will know, and I'm sure in Indonesia it's the same, that we have different hospitals with different specialty. We have hospitals that take care of infectious disease. We have hospitals that take care of burn. So this precisely why the clinical syndrome and the manifestation of the patient must be understood well. So let me just touch a bit on the anatomy of the disaster, the biomechanism of the calamities, what we term as the physical causal factor, crushing, stampede, and the non-physical, of course, we talk about chemical, water, and fire. And we already heard just now about the climatic causal factor, the typhoon, tsunami. I just want to mention now we have serious concern about climatic change that have caused a very serious impact on the severity of some of the major incident and disaster. Like we have seen in Dubai, suddenly they have a massive flood, and which was most unpredictable. And this is really caused by the climatic change or the thinning of the ozone layer and so on. Right, in the physiology of the calamity of disaster, of course, we talk about the loss of life. Here now, the forensic activity will be very, very significant. We cannot ignore the part about the loss of life, need to have the body identification and so on and so forth. And this is also part and parcel of disaster management. Now, without doubt, injuries, physical pain, and psychological response, acute and delay are all the core business of the responders. And the responders must understand too that by giving an intervention on the site, they must also understood about the metabolic response. What will change after the first management, subsequently, the pathophysiology may change the patient's, what we call the patient's metabolic response. Now, I will talk a little bit about the issue of the metabolic response in a crash syndrome that have caused morbidity and mortality. Now, this was the latest. This was a few days ago. One huge tree fell onto in the middle part of the Kuala Lumpur city, in front of one of my favorite hotel, the Concord Hotel, where I used to go and listen to some music there. But anyway, what happened then is that crash created a death of a driver in a car. This is just very unpredictable. Suddenly, it just fell right in the middle of the TT. And I just want to pick up a few more incidences that relate to crash syndrome. And I'm just going to show some pictures. And this is later on, we'll go into the discussion of crash syndrome. Now, this is the first one, the latest one that we have experienced. And there was this very serious incident on the 21st of August 2013, where the highest mortality of a bus crash incident in the Malaysian history. This is where very commonly in Genting, this is the Genting hill, where at the top of it there's a casino. And there have been many bus accidents at the way down from this Genting casino area. So this was in August 2013, and there was a lot of issue here. I'm not going to go into the specific, but just to show that there is a huge, what we call impact, and there has been a lot of unfortunate casualties. And that was the situation. And the wreckage have created about 48 deaths and so on and so forth. I'm not going to go into the specific on this one, but the rescue activity was very, very complicated, and it is really not for untrained personnel. And this is to rescue, and we managed to save some life. Okay, now there is another bus accident also in the Genting area, where it's also another situation where the bus crashes into the side of the hill, and of course created problem. Yeah. And this is only a few months later, and there's 33 injured. Okay, and there's another incident. This was in 2010, a huge, massive accident along the highway that create another situation of a crash between buses and several vehicles, and this create a situation of crash syndrome as well. And as you probably can see, in Malaysia, we have a lot of man-made incidents. Despite the fact not having natural disaster, we create our own. Now, so anyway, I'm just going to go a bit on some of the management of crash syndrome that will relate to what we term as the preparation for the responders. Now, I think we also heard about a few months ago, or a few years ago, there was also a stampede in one of the stadium, a football stadium in Indonesia, that have created crash injuries and crash syndrome as well. Now, let me just touch on crash injuries and crash syndrome, which is different. Precisely why the responders must know, even in crash, there's difference between injuries and syndrome. Now, we talk about total quality management process. Now, I just want to talk about this a little. Critical intervention, avoiding smiling death. I'll explain a bit more on smiling death later. Now, crash syndrome is a specific situation where it's a medical condition characterized by a major metabolic response, metabolic derangement. shock, and multi-organ failure after crushing injury to either localized or generalized musculoskeletal system that have caused systemic manifestation or amplified metabolic response. Now, it is easily undiagnosed because it is not so obvious. What you see is only the crushed part of the body. But what happened within the pathophysiological response is something that is of huge concern. Now, it is very common, and clinical syndrome as such is very common in earthquake, landslide, collapsed building, entrapment, and so on. Now, crush syndrome, as you probably know, at one time it was used as a death penalty. And if you look at some of this crush syndrome in many of these situations, it's extremely common. Now, if you actually evacuate patient or victim or survivors from crush syndrome, don't assume that you have achieved success because the crush syndrome have got deeper impact. Now, crush, however, if it is compressing a musculoskeletal system that's caused severe tissue damage, it can either be just a crush regionally, or otherwise it can be a crush syndrome. Now, this is an example of a crush injury, but this is severe, but it may just cause injury to that part of the body. However, in crush syndrome, in the crush situation, it may just about lower extremities, upper extremities, and so on. But in the crush syndrome, it will impact on the total body response. So I'm not going to touch too detail on how to manage it, because later on we'll create another workshop or skill training on how to manage it. But I just want to emphasize the point that the consequence of the crush syndrome require a team response and early intervention and so on. So this is some of those pathway, but I'm not going to touch into that. I just show you all that this is a pathway. Now, definitely, the initial intervention require adequate resuscitation and stabilization, and also require an awareness. If anyone is been what we call, if any one of those survivors that have been rescued from a massive crush situation, be careful, because although we see the patient is looking fine, but the metabolic and pathophysiology response, which is not seen, is quite serious. Okay, let me give you a situation right now. When I talk about avoid sudden decompensation or smiling death, there is a situation at one time where a patient, a survivor of a crush syndrome in Chengdu, and I'll show you the picture later, where the patient or the survivors was brought out of the crush situation, and the person is perfectly all right, and suddenly the patient died a few hours later. Okay, let me just show you. This is the person. Actually, this was an incident in Chengdu earthquake, and when he was actually rescued, he was able to talk to his wife. He was brought to the hospital, and then a few hours later, he died. At that time, he was smiling. He was quite happy when he was rescued. Now, this situation is somewhat the same in this situation as well. You know, when you see a crush like this, so very important that we actually have to manage the situation as soon as possible. And if you look at this intervention using a lot of fluid, and I just want to mention that when you have crush syndrome, you have a lot of anaerobic metabolism. They have got a lot of lactic acid, a lot of byproduct of metabolism without adequate oxygen. Now, because of that, we have to flush in a lot of fluid. And this is what we term as dilution is a solution to the pollution. So rescue activity must commence with a lot of fluid resuscitation. Okay, so just to finish off my presentation for this part of my presentation, intravenous hydration up to about 1.5 liter per hour should continue, although it intention to prevent prevent hypotension, but also to dilute all the metabolism that have occurred during the crash situation and during the anaerobic metabolism. Now, I would definitely not go into the specific of the management. I just want to show to you everyone that this probably completely be ignored by those who've been rescued from the crash incident or from the earthquake or from the stampede. Okay. Now, sometimes they may not cause death, but they may cause multiple organ failure. They may cause some of the failure of some organ, or most importantly, the death may occur much later, maybe a few weeks later, or for that matter, a few months later. Now, very importantly, the impact to the cardiac integrity. It may cause cardiac arrhythmias, it may cause myocardial infarct, which may actually cause death later. I just want to remind everyone that actually we have a lot of experience on dealing with some of this crash injury that due to accident when we actually excavate them from the crash vehicle, and we are fully aware that we have to deal with crash syndrome. So now if you look at this, for example, this crash situation is quite massive because a lot of the soft tissue is already damaged. You can see the color of the skin and the color of the whole limb is already discoloration. And this kind of situation, quite clearly, it may cause crash syndrome because the amount of soft tissue damage is already quite significant. Now, definitely later, it will affect the lung and it will cause adult respiratory distress syndrome. Now, I just want to mention this, that actually a lot of this crash syndrome occur in the pelvis because pelvis is huge bulk of muscle and also skeletal. And precisely, I invented this equipment called the Nina pelvic clamp, and just to make sure that we actually manage the bleeding as well as contain the crash so that the crash syndrome or otherwise the anaerobic metabolism do not affect the patient's life. So this is just an example. So as I was saying to everyone just now, that this crash syndrome was discovered by Eric Bywaters, and it's been recognized that it may cause mortality because of the situation where we have rhabdomyolysis, breakdown of skeletal muscle, which is damaged by ischemic and anaerobic metabolism, and with massive soft tissue injury, which is often undiagnosed, creating crash syndrome undiagnosed. So I'm just going to finish off by just mention again that though we train responders to respond well, they are quick to arrive at the site, they are quick to take out victim, but if they don't know about some of this clinical syndrome, it's just a matter of bringing out survivors one point to another, but the mortality or the morbidity can still happen. So crash syndrome is something that we have to train the responder to appreciate. And at any time they see a patient that has been buried for a long time or been in a rubble or in a earthquake or in a situation where, especially like in a wrecked vehicle, and if they see that quite a significant part of the body is been crushed, always remember crash syndrome. So again, as I was saying, it can affect kidney, nephrotoxic situation because of the myoglobin or methemoglobin, causing the infarct, and can cause acute renal failure. And this is something that most of the time not appreciated or not predicted. And again, as I was saying, cardiovascular system, the rhabdomyolysis, as the muscle cell dies, they absorb the sodium and the calcium, and they release potassium and the myoglobin phosphate, thromboplastin, and they can create problem to the cardiovascular system. And as I was saying to you just now, sudden decompensation after extrication have led to what we term as a smiling death. Smiling, the patient will be happy that you extricate the patient, from the rubble. They'll be talking to you for a while, and they may call in that situation in Chandu. The survivors call the parents, call the wife, and said that he has been extricated safely. But when he arrived at the ward, for a few hours later, and that's where mortality occurs. All right, so I hope I have impacted upon you. The crush situation can start with crush injury, blast injury, bone injury, burn injury, and prolonged decompensation that have, like they were saying, that if the crush is less than 4 hours, it maintains a crush injury. But more than 4 to 8 hours, it can cause crush syndrome. But I'm not so keen to apply this time perspective. I think it had to relate to more of the severity of the crush and also relate to the significant amount of soft tissue that have been crushed. So, of course, we also can deal with compartment syndrome, which is actually part of the crush injury, which can later on lead to crush syndrome. So precisely why, if we have crush injury that have caused compartment syndrome, decompression must be done early before it become a crush syndrome situation. Because in the compression may cause anaerobic metabolism. Right? There were a lot of what we term as scoring system to identify the crush syndrome, which we can actually make people understand in order for us to have the sensitivity or the potential of crush syndrome. So I'm not going to go into the detail, but I'm just going to mention again and again that at any time when we deal with patient in the situation of massive injury, we have to appreciate the part about we are not only doing intervention, we also clinical intervention, but we also do humanistic and caring aspect and counseling and support. So we have in this situation in Malaysia, we have created many what we call protocol. And in that protocol, we actually train our responders to appreciate the process, but also to appreciate and to know clinical intervention. Now, this is why in which I started this program called iMyrex in Malaysia, which then I proposed to be started in Bandung in the form of Jamboree. And I'm so glad to say that we are going to our second Jamboree. And inshallah, this Jamboree will be much better, preparing our responders not only for the process of rescue, process of evacuating survivors, but also process of on-site intervention appropriately to the clinical syndrome. So I'm going to finish off by thanking everyone for listening to me. I welcome any question, but I was just in a way giving a bit of a brief presentation to make people appreciate that crush syndrome is one of the clinical syndrome in the disaster. It can be many more. I think in my series of lecture on clinical syndrome, for example, we talk about near drowning, we talk about burn, and we talk about massive bleeding, and we have actually have to introduce the concept of damage control resuscitation, and all this skill is mainly to make sure responders not only transport patient out of the disaster area, but initiate early intervention to prevent morbidity and mortality for the survivors that we have saved from the incident or from the disaster site, to give meaning and to give more meaning to our intervention with the skill that relate to the clinical syndrome that have happened to the survivors during the disaster. So inshallah, we hope we can then upgrade the skill, the competency of the responders in order for us to give the best for the survivors of all type of calamity, disaster, or major incident. With that, thank you very much. I apologize for making it brief, but this is more to sensitize the part about in disaster management. There's something called clinical syndrome, and we have to train. And unfortunately, some of the clinical syndrome are so many types. We have ranging from burn, fire, near drowning, and I have to also touch on psychological response, which is also a clinical syndrome. Okay, so thank you very much. I welcome any question.
Thank you, Prof. Abu, for your intuitive presentation. I'm sure our audience has learned much from you today about the clinical syndrome in disaster incidences, including cross syndrome and its major metabolic system derangement, pathophysiology and clinical manifestation, and the difference between cross injuries and cross syndrome. Okay, before we move on to the Q&A session, we move to our fourth and last speaker. Our fourth speaker is the committee of our next event, International Jamboree Faculty of Medicine of Unjani 2024. Our staff in Faculty of Medicine Unjani and currently pursuing a master degree in Universitas Indonesia, and also the Vice Director of Public Relations and Marketing in Paramartha Hospital. Please join me in welcoming Dr. Glenn Glady Prakasa, who will be presenting the topic of the Jamboree presentation. Hello, Dr. Glenn.
Hello, Rhea. Thank you so much for introducing me. Hello, everyone, for who joining this webinar session. We have listened and learned extensively about how disaster strikes, and one thing that is certain is the health crisis it brings about. Hence, it is about very impetus that drives our Unjani Medical Faculty to organize the International Jamboree event. On this occasion, I would like to briefly explain about this year's Jamboree event. It is our earned hope that many healthcare professionals and students from abroad and from national that can participate in this event. I would like to share screen. Okay, guys have seen my share screen. I would like to go to full screen. So this is our event at this year's. This is our International Jamboree Unjani Medical Faculty, International Major Incident Exercise, Faculty of Medicine, and the Universitas Jenderal Ahmad Yani 20 and 24. This is our yearly event. So we hope the next year, 20 and 25, 20 and 26, we will always plan for this event. So I will go to the next slide. This is our main theme and focus for this year, aligning medical capabilities and building medical teams' resilience in disaster preparedness. According to the focus, we have some goals on this event. The first is introducing disaster in Bandung, also Indonesia, and how the health perspective in disaster management. We all know that Bandung is a city that they make the, from the disaster before. After a lot of earthquake and a lot of volcanic and tectonic earthquake, that is Bandung have. Okay, and then we make participants have equivalent abilities in disaster health management, and also we understand the structure of coordination during disaster in Indonesia. Participants are able to understand the limits and the capabilities as a health team in disaster events. Participants have equal ability as a first responder in health fields. So in accordance with the main theme, we want to create a health team resilience that is ready to face disaster and responsiveness in the provision of handling patients instead of a team that can do everything. So we have three phases on our event this year. The first is open access webinar that you held that held on this day, and you have joined this webinar to learn participant and increase curiosity towards Unjani Medical Faculty International Jamboree. The second, we will have the scientific webinar that is closed for only the participant. This activity aims to form an understanding of all participants, and the last is our main event, the hands-on and the competition, International Jamboree main event. So this is the open access webinar. This is public. This is this is the this held on this day, and you have joined the webinar also. Thank you so much to Prof. Abu, to Dr. Raditya Jati, and also Dr. Bagus as our speakers, and also to our Dean, Dr. Wendra, that give our motivation for this event, and also Dr. Odi. So we are going to the next event, the scientific webinar. This is closed for only the participants that have registered to Jamboree. So this is the lecture that will given to the participants. The first is introduction. It's all about Indonesian and all official responsible for the disaster. As mentioned before from Dr. Raditya Jati, thank you so much, Pak Raditya Jati. as the Deputy Minister for Strategy and for System and Strategy in BNPB. The second lecture is Disaster in Indonesia, Bandung, firstly. And the next is the Bandung Land Contour that will be given by the Professor Irwan from ITB for Institute Teknologi Bandung. Then next is the Command Center and Disaster Volunteer Coordination. And then about the EMT, Emergency Medical Teams, and also we give the lesson and basic preparation for disaster zone. Then we go to the health impact on disaster and also first aid and triage, and also the last is the basic patient transport in disaster zone. We go to the main event. This is the hands-on and competition for all participants that have registered to our event. We give the we go to the we get the online course, and then we got the hands-on workshop about emergency response and disaster, and the third competition in emergency response and disaster, and also the cultural night and recreational program. We don't only have some lecturer on only some competition, but we also have the cultural night and the recreational program. The cultural night, we will provide all of the participants from every nation or country will give their own cultural. We hope they will bring some maybe dance or food or other things that we try to present in the cultural night. And also we have the recreational program. The recreational program is not only recreational, but it's also an educational program that we will go to the Tangkuban Perahu, which is the one of the main volcanic site in Bandung and still active volcanic. Okay, this is our facility and advantage. We'll give camping utilities, we'll give some food and beverage during events, so you don't need to bring anything. The fifth is survival kit and international certificate, and also transportation to the venue, valuable experience, recreational program, and souvenir. We still bring your main item or your equipment from your institution. So we have another point for the team who bring the best equipment. Okay, this is our trophy, the International Major Incident Exercise and Competition Winner Prize. The first is the Rector Trophy, Certificate, and Cash Reward. We divide this, for this event, we divide the participant into two categories. The first is the professional and the student categories. Then we have the best teamwork, the best performance, best Hercules, and also the best team leaders. So this is our venue for this year. This is Curug Layung that located in Lembang, which is very nearly to the Sesar Lembang, who goes the Bandung with the risk of and the hazard of the tectonic earthquake. So we have a very beautiful curug here ya. Curug means air terjun. Kalau di Sunda itu namanya curug seperti itu. And then this is our present to you some video about our last Jamboree. Sorry, may not listen the sound ya. Maaf, sudah terdengar, Dokter ya?
Sebuah Jamboree internasional tentang simulasi penyelamatan korban dalam situasi bencana diadakan di Bukanagara, Cisalak, Kabupaten Subang. Jamboree yang diselenggarakan oleh Fakultas Kedokteran sebuah universitas swasta di Cimahi, Jawa Barat ini diikuti oleh tenaga medis, dokter, dan perawat.
Dan di Indonesia itu belum pernah ada Jamboree tentang pelatihan kegawat daruratan.
Indonesia calls you to the second International Medical Jamboree. Experience more than ever before. Lectures, workshop, and thrilling competitions. Camp under the stars. Learn from the international legends, connect, compete, and discover in the celebration of medical brilliance. Mark the date. Elevate your journey. Be part of the extraordinary. July 2024. Join us.
Okay, so dear all participants of this webinar, this is our event will be held on July 9 until 11, 2024 at Surupayu, Lembang, Bandung, Indonesia. As the main focus, we are together aligning and building the team of health team resilience. So this event can only be participated with the healthcare provider. So for the registration fee for the international participant will be, for the professional categories will be 750 USD, and for the student will be 600 USD. For the national participant will be 5 million rupiah, and for the student participant will be 4 million rupiah. And this registration is for 5% for a team. So you need to make a team for 5% to get the registration fee. If you have only one or individual registration fee, you can contact me or contact another person in this flyer. They should put you as a new team with another individual registration team. So maybe that's all from me, Dr. Rea. Thank you very much for the time, and we get back to the moderator. Thank you so much.
Okay. Thank you, Dr. Glenn, for your excellent presentation about the International Jamboree of Faculty of Medicine Unjani. Okay, thank you for your time and attention. Now let's open the floor for questions from our audience. Please write your question in the Q&A box and I will read them to the speaker, and also state your name and affiliation while asking your question in the question box. I see some question already written in the Q&A box. First is from Fitri Septianti Sumardi. I think the question is for Dr. Bagus. Dr. Bagus, how could we manage the front line and volunteer in communication system management as a medical team to save as many as possible? Could you give guidance and direction? Thank you so much for your advice and direction.
Okay.
Silakan, Dr. Bagus.
Yeah, thank you, Pak Fitriati. Yeah, in the disaster response management system, we ideally work under the supervision of a command post, yeah? Because under the command post there are 8 clusters. One of them is health cluster, and then any medical personnel, doctor, nurses, environmentalists, nutritionists, they have to report to the health emergency operating center. What you have, I have 1 doctor, 3 or 4 nurses, 5 volunteers with the specialized in this, and we bring equipment, drug, everything. And then the health cluster or health emergency operating center will assign this team to the designated area, because there are many displaced person, 2 or 3 areas, they will designated them, and then they can perform under the EMT guideline. Maybe there is a mobile or medical team, there is a very basic EMT facilities, so they can do that. if not reported to the command post, is not recognized, so they don't have get a area that really need their help, will be duplicating and overlapping. So it's very important any medical team, nursing team, or health response team come to the disaster area must report to the command post under the head cluster. I think that.
Okay. Thank you, Dr. Bagus. The point is, the medical team or nursing should be report to the post, and then we could distribute the team as equal as possible in the area of the disaster. Yes. Prof. Abu, is there anything to add?
Yes, basically, this is very important in terms of coordination. There are risks that the responder may be facing. Precisely why, when they report to the incident site, the assessment of whether the intervention or the rescue can be done is already been done by all the officers on site. Like in Malaysia, we have the police officer or the fire and rescue. Now, the front, what we call the ground zero, the responders the early responders, usually the fire rescue or the police, they have done the assessment to allow the medical responder to go in to do the rescue appropriately. Now we actually must understand the concept of primum non sere. Primum non sere means do no further harm. And we will not want to have any other injury or whatever problem that relate to the responders. I just also must mention one thing, that we not only or must not forget the part about what we term as the impact to the responders is not only physical trauma, but also psychological. Now, I think we must appreciate that after the incident, management, and when they have and everything have settled, there's something called the psychological first aid, or what we term as psychotherapy, for the responders. And I just want to appreciate the fact that although this may not be done during the Jamboree, but I just want to mention that in Malaysia, when we have all our team that come back from countries like Indonesia or the Philippines, when they come back, we do a bit like what we term as psychological first aid or psychotherapy for them as well. So just remember that we must not only concern about the safety in the form of physical injuries, but also in their psychological trauma. So that's all from me. Thank you.
Okay, thank you, Prof. Abu, for the addition. I think we have few questions from Nick from Terengganu, Malaysia. Thank you for the great and informative lecture. I would be very much happy if you can share tips, guidance, and advice on. The first one is mental preparation of the staff involved in disaster management as to prevent PTSD. I think the first question first. Prof. Abu, maybe you can answer first about this question.
Yes, thank you very much for that question. The truth is, it is something that we have to train. I just want to mention a few terminology, and that's one, we call it emotional intelligence. Now, I incorporated this training when we train responders, and also, of course, in the emergency specialist training or in the training of perawat or nursing, they must go through. Now, what we term as to create a robust, resilient psychological framework. I have this quotation, and I always say, stress inoculation for stress immunity. That means we stress them. We subject them to certain challenges and see how they can manage. And the other one is also we actually create a situation by training them to be able to manage their own stress. This is another training entitled Critical Incident Stress Management. Now, one of the most important aspects, not only for disaster rescue, but more for our livelihood, we have to train our younger generation in adapting for managing their own stress. Because of late, because of the advent of digital technology, the emotional intelligence of the young generation have been compromised. I just want to say it again that not only is needed for their disaster management preparation, but it's needed for their daily life. So we should incorporate that in our training program to maintain emotional intelligence. And this is something recently have come up what we call digital emotional intelligence. And this is something that I cannot be giving a lecture because it's a bit too long for that, but it is a very important question. That psychological framework of the responders, of the medical student, of the nursing student must be appreciated, that it has been quite clearly can be compromised by digital technology. That's all I want to say now, but of course I can give one lecture on it anyway.
Thank you, Prof. Abu. So it is quite important to give a training to medical team before they go in the place of a disaster for their mental preparation. Okay, Dr. Bagus, any addition to that question?
Yeah, just a quick.
Yeah.
I really strongly agree with Prof. Abu. Usually we just do psychological first aid for the victim, not for the rescuer. So it's very important to do so because rescuer face the very, very extreme situation will affect their mental and emotional stability. So in Indonesia, we still now focus on how to reduce the negative impact of silent trauma by applying psychological first aid, etc. Usually focus on children because they are affected more than the adult one. I think this one.
Yeah, thank you, Dr. Bagus, for the addition. Okay, the next question from the same person before. How to prepare kantor gawat darurat or emergency department to expand or increase capacity in order to receive disaster cases or casualties without disrupting existing services? Prof. Abu, you can answer the question.
Yes, this is very, very interesting. Actually, I really like this question because first and foremost, when we have a disaster, the life of the survivor that we rescue is equivalent to the patient that we manage in gawat darurat. So we cannot actually bring the victim or the victim to gawat darurat, affecting the management and the capacity of the cases that we manage in gawat darurat. So what do we do? Now, this is why we have to divide the cases into three groups: green, non-critical, semi-critical, and very critical. Unfortunately, we tend to bring all the patients to one rumah sakit. Now, because of the fact that convenient for the relative and all that. So if we can do that in one big hospital, that's fine. But most of the time, not many hospitals can cope with so many patients. So what we do is like this. First and foremost, all the green patients, all the patients non-critical, ideally, we don't need to bring to hospital. We try to manage them in somewhere else, either on site or bring it to a camp somewhere in a football field, anything like that. We train their wound, they train everything, and we can send them home. But of course, all the cases must be documented. Sometimes we send them home without documentation. We don't know whether the patient has been lost or whether the patient is already been rescued. Wanting documentation is very important. Number two, all the semi-critical patients that actually do not have life-threatening condition, we can treat them and send to a hospital or send to a clinic where it is actually can be managed away from the hospital that manage critical patient. Now, as I was saying, no way we can actually prepare for a disaster in a big way because the resources will be wasted if we create so many beds, but actually the patient, the requirement for that hospital is not. So we maintain our usual capacity for treating daily life, but the most important, what we term as resource mapping. When we map the resources, We know where to send the patient when such occurrence happen, and we call it resource metrics and resource mapping, that the moment an incident happen and beyond the capacity of one hospital, we have to distribute the cases to different hospitals. And that's called resource metric and resource mapping and distribution of cases according to their severity. Thank you.
Yeah, thank you, Prof. Abu. So it is important to distribute the victim or casualties to more than one hospital, or in the disaster place, the medical team need to have experience to triage the casualties. So we can send the critical to the hospital and evaluate or assess or give management for the non-critical patient in the area or in the clinic close to the place of disaster. Thank you, Prof. Abu. Dr. Bagus, any addition for
Yeah,
the
briefly, yeah. This is outside hospital, learning from COVID-19 pandemic. So the Ministry of Health now have a project preparing for anticipating surge capacity for doctors, nurses, and health workers, because what happen if there are 3 natural disaster happen at the same time? We experience many times, so we lack of medical capability. We need more EMT to be built, established in Indonesia to handle the such capacity for the disaster.
I think you're looking at the field hospital. Yeah? You can actually create field hospital in order for us to manage patient outside of the ordinary hospital.
Okay, thank you, Dr. Bagus and Prof. Abu for that question. Okay, next question, I think from the same person before. How to convince higher authorities for money allocation in disaster preparation? Example for training, equipment, or collaboration. I think Prof. Abu can answer the question first.
Yeah, I think basically the most important convincing is of 3 aspects. One is called lesson learned and lesson identified. So this is why documentation and also report from a disaster must be done appropriately. Now, number 2, we have to actually, when we do a proper request, it has to be scientific. It has to be based on a proper paper with evidence base. Yeah. Now, actually, when we ask for resource development or more allocation, we have to actually explain clearly what is our capacity. So, and what is our capability. Now, resources means equipment, facility, and also human resource. Now, one thing we always forget that actually one of the most important resource is to get funding for training and for sending them overseas. Welcome to Malaysia to train, to get trained, for example, So this is something that we always forget, the part about, we always think about equipment, we always think about infrastructure. But if we say that, look, our responders is not well trained, they may not be able to manage, because this is called the penny wise, pound foolish. Now, penny wise, pound foolish means you develop all the infrastructure, equipment very well, but the people who manage it are not able to manage properly. Now, as I was saying to you, that first, any incident that happened, we must do a proper documentation and create a proper assessment of our capacity. Now, show the evidence that our capacity is actually not actually adequate. The third one is when we talk about getting a proper allocation, it must include also skill development. Now, quite clearly that these are very emotive. What do you mean by emotive? And the time when the best time for us to request for the equipment or for the development of resources is when immediately after the incident happened, because it's still hot in the mind of the pemerintah. So we actually must hit it on the right time, when we put up the paper and request, so that the memory is still there and the emotion is still there. Now, most of the time when we request with proper evidence, with proper scientific calculation and so on and so forth, and during the right time, inshallah, you'll get it.
Yeah, thank you, Prof. Abu. So the documentation is important to give the to give to
Exactly. Yeah.
higher authorities to convince them to give us some training and etc. Okay, any addition from Dr. Bagus?
Yeah, outside this, if we depend on the central government budget for training, it's very low now because every time they're getting lower and lower. So our strategy is how to interact and collaboration with the local human resources development in the province. So we train them, we do training for trainers, we accredited the province human resources training program so they can allocate their own budget. This is very important because they have money for the local development for human resources in terms of disaster management. So we train of trainers, we develop curriculum and model, and we certified and accredited the office. The second, we do what we call it private sector's collaboration. So many private sector, they have their own money, their own budget. We train together, we share teacher, we share trainer, they share the money, and we get more and more people coming for the training because Indonesia now like 100 more million people with a high potential risk for disaster. So we have trained it very quick because if we do right now, we need 100 years to finish the training. That's just, it's not good. So we collaborate with private sector, with the business world, with local government, with military also. We train regularly with the military and the police. Thank you.
Okay, thank you, Dr. Bagus, for the addition. Dr. Glenn, you have something to add?
Okay, I'm sorry before Prof. Abu and Dr. Bagus, please correct me if I'm wrong. But as I know, we have also an assessment as a hazard and vulnerability assessment that will be very useful and for every hospital or every emergency department to convince the stakeholders or the higher authorities they can make another proposal. Because from the hazard vulnerability assessment, we can know that what is our hazard and what can we do before that disaster come. So I think one of my opinion or one of my recommendation that you use that HPA. You can also Google that a very lot of research about the HPA or hazard and vulnerability assessment that can also use from the healthcare provider or hospital or emergency department. And also like Prof. Abu said and or mentioned before that we can learn from the experience. So because experience is the best lecture for us about disaster. Maybe that's all, Dr. Rea. Thank you.
Okay, thank you, Dr. Glenn, for the addition. I think we can use the next question. This is from M. Fatoni from Faculty of Health, Universitas Brawijaya Malang. I have a question for all panelists. For Prof. Abu, Dr. Bagus, and you can add the answers. How about the role EMT and disaster nursing provide in each your country? Maybe Prof. Abu can share the role of EMT and disaster nursing in Malaysia, Prof.
Yeah, thank you very much. First off, we have seen that the role of first responder can be multiple. You have many roles. Now, of course, as I was saying to you just now, we talk about transportation, moving from patient from one place to other, the ability to rescue, to manage clinical syndrome, and to having to deal with all the disease or all the condition that has happened to survivors. Now, so if we put it down quite clearly, one is, of course, responding for disaster management in relation to clinical syndrome. The other one is to give support, assistance. And just now we also said that all the responders must know how to do what we call PFA, psychological first aid. Now the part about the nursing or perawat, which is forgotten, but not really managed, is actually the social aspect, what we call the social interaction. But in my situation, when I bring many nurses, especially the lady nurses to the site, they are very important to deal with the reality, to calm the people down and so on, which is quite clearly not been done properly. Okay, so the skill, as I was saying, clinical skill, very important. Psychological skill, very important. Support skill, also very important. Now, all this training must be holistic, must be complete. Now, in our experience in Malaysia, when we bring nurses to the site, all the support team, we divide them into different roles. Okay, the one that are competent, the one that's strong and resilient, we can bring them to the red zone or to ground zero. And then we have a group of nurses that we place them at the field hospital, and they're dealing with assisting. And then there will be a group of nurses that will be at the site where we have the dead bodies or the forensic, where we do what we term as psychological first aid for the relative. And there are a lot of others that provide support with food, with all the logistic in order to deal with not only the patient, the relative, and also the respondent. So we have to clearly mention their role and train them appropriately. Thank you.
Okay, thank you, Prof. Abu. Okay, Dr. Bagus, maybe you can share what about in Indonesia? How about the role EMT and disaster nursing provide in Indonesia? Dr. Bagus, you still mute.
I think the same what Prof. Abu said, and we just put all the activities EMT under the roof of we call it disaster management command post. So the head cluster will manage this, and the role of the nursing is very important. It's not just for the medical thing, but for the water, hygiene, sanitation, and environmental health is very, very important, especially when we have to deal with thousands of displaced persons in the one area. Water, sanitation, hygiene, environmental health is very, very important. I think this one.
Okay, thank you, Dr. Bagus. I think in Malaysia, Indonesia also similar, yeah, about the role EMT and disaster nursing provide. Okay, Dr. Glenn, maybe you can add something?
Maybe that's all enough from Dr. Bagus, Dr. Rea. Thank you.
Okay, thank you. Okay, next question. To Prof. Abu from Fitri Sepvianti Sumardi. My question is, how should we make deal with climate change to avoid catastrophic? Thank you so much for your guidance and direction. I think Prof. Abu already answered this question in the chat box, Prof.
Yeah. I can explain again.
Okay.
As you know, in 30 years, Jakarta will be under the water, and also Manila is under the water, which is predicted because of the fact that increase in sea level, and also because of the thinning of ozone layer. Now, first and foremost, climatic change in the whole world is a real concern, a serious concern. As you all probably know, that there are a lot of very peculiar situations. Recently, there's flood in both in Medina and also in Mecca, as well as in Dubai. And subsequently, after the flood, then there was a huge snow in Dubai. Now, all these climatic changes is very concerning. Why do we have this climate change? Climate change is because of thinning of ozone layer and the increase of temperature throughout the world, where the dilution or the melting of the glaciers as well as the ice at the Arctic zone that have created increase in sea level. Now, increased temperature, increased volume of water, create a lot more flood, create a lot more whirlwind and typhoon and so on and so forth. Now, how do we deal with climate change? Precisely why we are moving towards reduction of the use of fuel, petrol, and reduce pollution. Now, that's why now we try to move towards electric vehicle, because one of the biggest source of pollution that can cause thinning of the ozone layer is actually from the fuel, exhaust pipe, and from all the pollution, and more so from the factories and so on and so forth. Now, climate change actually have to deal with preventing thinning of the ozone layer, preventing the melting of the ice from the Arctic zone and Antarctica. And most importantly, the management as such that the education of the people and the education, and of course, the commitment of government to reduce pollution and to reduce the thinning of ozone layer, which should become an agenda. I must confess that in Malaysia too, we are now talking about climatic change. And the change must be prevented individually, community, most important government, and the commitment of the whole world. That we have to save the world. Now, of course, preventing falling of trees, preserving the ecosystem of the jungle and the villages with more natural resources. And most importantly, we do not want to sculpt the hill. As you all know, when we do a lot of agricultural development, unfortunately, that ecosystem have caused a lot of flood because trees are important to prevent flood, and all these kind of things. So I can go on talking about it, but it's a very important agenda now. Thank you.
Okay, thank you, Prof. Abu. So for prevent the climate change, I think the first step we can do is to reduce pollution in our area by using electric vehicles, by example. Okay. Dr. Bagus, you have something to add?
Yeah, quick. In Indonesia, we have two not actually different, but two main area. First is disaster risk reduction. This is for natural disaster. And then there is a climate change adaptation. The difference is climate change only deal with weather and climate related disaster. But for disaster risk reduction include geophysical disaster like earthquake, tsunami, and mountain eruption. So in Indonesia, we integrate climate change adaptation and disaster risk reduction. Climate change under the Ministry of Environment and disaster reduction under BNPB. So we actually married and hybrid this. So not overlapping, not just set aside, but they reduce the impact. Okay, thank you.
Okay, thank you, Dr. Bagus, for the addition. I think the integration of both aspects is very needed for the prevent of the climate change and etc. Okay, I think this is the last question, Prof. and Dr. Bagus. Hello, Prof. Abu and Dr. Bagus. My name is Afif. This is from Afif. Please allow me to ask how to build good channel and mechanism in remote or underdeveloped areas regarding the reach of emergency medicine, both in terms of research and equipment requirements. Is surviving with minimal resources and equipment enough, or there is a need to develop qualified human resources knowledge and experience in handling emergency medicine itself? So what do we actually need to do first? Is it developing the quality of human resources or the completeness of medical resources and equipment? Because we have to adapt to the situation in regional areas and government institution. I think this is the long question. Maybe Prof. Abu can answer the question first.
Yes, of course. It is very simple. The approach is very simple. Everything that we plan must be very scientific. Now, first and foremost, we have to do what we call risk analysis, and we match it with capacity. Now, we always have our wish and what we want to do, but it has to be justified by certain analysis. Now, quite clearly, in a remote area, there are certain risks. It has to be identified. If there are certain requests, it has to be identified. We cannot just build resources and provide resources without any evidence. So first step is that if there is any need to develop resources in all aspects, equipment, structure, skill training, and so on, in wherever it is, in the remote places, if there's any need for it. So we do risk analysis, we do need analysis, and we match it with the capacity. Now, for that kind of risk, for that kind of need, now we have to equate that for what kind of resources we have to develop. Now, with this kind of analysis, and then we bring it up to the pemerintah and said, look, this is our risk, this is our need, and this is the capacity that we want. And that is the best way to request for any resource development. we cannot be based on anything to do with gut feeling and anything to do with just a wish. It has to be supported by evidence. And as you know, the government resources will be allocated according to the need analysis and the capacity requirement. So there's a very simple answer. And as I was saying, and no government will not develop resources if there's any need for it, if there's any evidence for it. So we go by that formula, inshallah we'll get what we want.
Okay, thank you, Prof. Abu, for the answer. Maybe Dr. Bagus have something to add? Dr. Bagus, you still mute.
In Indonesia, we empower the puskesmas, the community health clinics, health center. Also, we maximize the role of the volunteers, and then family resilience, and then also women resilient program, because they are the first responder, especially the area with need fly by helicopter, because it's far away in the very remote island. So takes like 3, 4, or 5 days to get there. So we have to maximize, empower the local resources, puskesmas, and then the volunteer, bidan desa, and then all the health workers resources in that area. Thank you.
Okay, I think from Prof. Abu, we need to analyze first before we make a demand either human resources first or equipment first. Yeah. Okay, Dr. Glenn, you have something to add?
Maybe nothing for the question, but we will delve further into EMT and how we manage health crisis in disaster at the Jamboree. So for all participants, come join us at this event because it's a very limited seat. We only provide for 20 teams from international and national. So register soon, or maybe you will not get a chance to join this event. Maybe that's all, Dr. Ria. Thank you so much.
Okay, thank you, Dr. Glenn. Okay, I think this is the end of our discussion session, Prof. Abu and Dr. Bagus, because we have limited time for this webinar. Thank you again.
Thank you, Prof. Abu.
Hey, thank you, Pak Bagus. See you soon. I'll be coming to Bandung soon, okay?
Ya, ikan paten itu.
Yeah.
Thank you, Prof. Abu. Thank you,
Restorannya enak
Dr.
banget.
Bagus.
Restorannya di
We'll
Kuala
see you all
Lumpur
in
enak
Indonesia
sekali.
soon. Okay. Thank you
Prof.
very much.
Abu.
Thank you, Prof. Abu.
Come to Malang.
Yeah.
Okay, we'll promise you to come to Malang as well.
Yeah.
I've not been there a long time.
Okay.
Okay. Thank you for your attention and participation. We have come to an end of our webinar on whole aspect in disaster management, Road to International Jamboree Faculty of Medicine Universitas Jenderal Ahmad Yani 2024. I hope you enjoyed this session and gained valuable insight and knowledge from our speaker, of course. We also have some lively and engaging discussion and question from the audience. Thank you for your active involvement and contribution. Before we close this session, let me remind you again that the healthcare provider and health or medical students should join our next event as presented before, International Jamboree Faculty of Medicine, Universitas Jenderal Ahmad Yani 2024. I want to thank you, our speakers, once again for their time and expertise. Let's give them a big round of applause. And I would also like to thank you for the organizer of this webinar for making this event possible. Please give them a hand as well. And finally, I would like to thank you for all who joining us today. I hope you learned something new and valuable from this webinar. Thank you very much and have a great day. I return the event to the Master of Ceremony. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much for Dr. Rea for guiding the material session, and thank you very much to the doctors who provided the material. Before going to the final session, there will be a certificate presentation first. Next to Zidan.
Okay, thank you, Nadia. First is Dr. Bagus Yono, MPH, for the committee. Okay, in second of 3, 1, 2, and 3. Okay, thank you, sir. Next is Prof. Dato Sri Dr. Abu Hasan Asari bin Abdullah.
Thank you very much.
Okay, for the certificate. Sorry, doctor, there's been a mistake. Okay. In count of 3, 1, 2, and 3. Okay, thank you, doctor. And for the last certificate is for Dr. Glenn Glady Prakasa. Okay, in the count of 3, doctor. In 1, 2, and 3. Okay, thank you very much. For Dr. Bagus Cahyono and Prof. Dato Sri Dr. Abu Hasan Asari bin Abdullah, and for Dr. Glenn Glady Prakasa for the guidance and for the material. Maybe I'll be back in Nadia. Enggak, kan speaker semua ini moderator. Okay, thank you very much. Dear audience, we've reached the final agenda. See you on the next meet. We apologize if there is something that is not acceptable from us and the committee to all the attendants. I, Muhammad Zidan, and my partner.
I'm Nadia Zalianti, and thank you. We'll see you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. See you.